that was shortly before the launch of the elective recovery program. So now is, I think, an opportune time to review where we've got to and where we need to go to. Next slide, please. The elective recovery program was launched just about 1 year from now, 1 year ago. It's a 3-year plan, and nobody ever expected that we'd be able to deal with the elective backlog within 12 months. Everybody who's listening to this will know that the pandemic led to a significant increase in the waiting list, with some patients waiting very, very long times. The cartoon at the top of this slide really demonstrates what we're trying to achieve, and the targets that have been set for the National Health Service over the 3 years. Initially, last July, the aim was to make sure that nobody was waiting for more than 2 years following referral. This April, we hit another milestone when the plan is that we will reduce that time down to 18 months. In a year's time, it will hopefully come down to 15 months maximum wait. And by March 2025, nobody should have been waiting more than a year. The reality is that we've made pretty good progress on that, and I'll show you some numbers around that, and a delivery architecture that focuses upon the very long waiting patients has been supplemented by something that I think is essential. If there's one message I've got, is that carrying on doing what we've been doing before, then we'll never get out of the hole we're in. We really do have to change the way we do things, the way we deliver surgery and outpatient care. I'll talk a little bit more about that. The problem is that because of the shape of the waiting list, the next milestone is always more difficult than the last milestone, because the numbers of patients in that cohort are much, much higher. And everybody will know that the NHS workforce has been working above and beyond for several years now, initially the pandemic, and now trying to recover from the pandemic and deal with this backlog. And there are lots of pressures. A year ago at this time, there was a COVID wave. There were lots of workforce unable to work. Now the challenges are not necessarily around viruses, but we've got industrial action, and that's again affecting our ability to deliver care. Next slide, please. So what are we doing? We are aiming to recover services by delivering real, proper transformation. There's an increasing focus on the separation of emergency care from elective care to make elective care more resilient. There's a focus on making sure we get the very basics of administration and management of the patient pathway effective, so that booking is reliable, the waiting list is accurate, prioritization is appropriate. 80% of our waiting list is in the outpatient service, and we've really got to rethink how we deliver outpatients. Those clinicians who are listening to this will know that outpatients has been remarkably unchanged for the past 30 years. And we do need to do it differently if we are to provide more efficient, productive, effective care, which is probably going to be better for patients as well. We're also aware that there's considerable variation in service and outcomes between different organisations, and that reduction of variation, the very bedrock of the GIRFT programme, will be essential to helping to improve those clinical services. And at the same time, we do need to remember this is a service for patients. This is not a service for the staff who deliver it. So we really do have to empower patients and place them at the centre of everything that we do. Next slide, please. So what have we achieved? Well, number one was about the 104-week waiters, patients who've been waiting more than 2 years for treatment. This time last year, there were 22,000 of those patients, and about 70 and about 50,000 patients who would have become 2-year waiters if they didn't get treatment by July. And they all got treated. And actually now there are less than 1,200 patients who've been waiting more than 104 weeks, and the vast majority of those are either waiting that extra time because they've chosen to wait that length of time, or because they've got a very rare and complex need. And part of the long-term transformation is to expand our ability to deal with some very rare and sometimes very complex patients. The next challenge will be to get down to 78 weeks to treat all those patients who've been waiting more than 78 weeks by April. This time last year, there were about 1.7, 1.8 million such patients, and including those patients who've joined the cohort ever since. You can see from the graph that the numbers of patients in the cartoon in the graph has come down considerably. In December, that cohort was down to just over 200,000. It has continued to come down, and data that I've seen suggests that we remain on track to deliver that target. Next slide, please. The next issue, the next target that's related to elective care is the issue of cancer. As a urologist, cancer and elective care are one and the same thing for me. I spend half my time doing one and half my time doing the other, and that's true of many specialties. And so, artificial separation of the process of the challenges is unrealistic. The first challenge that we had in terms of elective recovery was to drive up the 2-week wait referrals. 2-week wait referrals fell significantly during the pandemic, and that meant that there were many patients likely with potential cancer who'd not sought treatment. That initial objective to drive up referrals has been succeeded. We've had more than pre-pandemic levels for a year or so now, and November 22 was actually the busiest month on record for 2-week wait referrals across a range of specialties. That's placed our services under extra pressure. This isn't dealing with pre-pandemic levels. This is dealing with levels of demand 120, 130% above pre-pandemic. And so it's placed it under some strain. And the decision was made last summer to bring cancer a little bit closer to elective care in supporting those organisations who are having difficulties in delivering. And that has been successful. Although we're not yet down to pre-pandemic levels, we are on track to do so. And the numbers of patients who've been waiting more than 62 days for their cancer treatment is falling month on month and continues to fall. Next slide, please. So what have we learned? Well, we've learned that the NHS should, the NHS has done a good job. People are working hard despite what are often very tricky circumstances, whether it's due to the pandemic, whether it's due to urgent care or social care problems, or as we face up to and deal with and manage the challenges around industrial action. But we do need to remember that patients are at the centre of this, because it's patients who are affected by this. And we need to put in place long-term transformational plans to ensure that when we get the waiting times down to an acceptable level, that we're able to keep them there. From a delivery perspective, we've worked very closely with those providers who've had the biggest problems, and we've learned from that. And we've been able to take those learnings and apply them in many organisations. And what we've learned is that when you've got a leadership team in an organisation that is supportive and engages, that they are able to deliver, and indeed they're able to take pride in delivering. At the heart is very, very basic operational management. As a clinician, it's not something that is naturally first nature to me, but accurate booking, accurate validation of waiting lists, making sure that patients are prioritised appropriately. Next slide, please. And this is an example. The North Bristol Trust at the end of July 22 had the worst national backlog position for cancer, with 34% of their cancer patients waiting more than 62 days. Within 10 weeks, they were down to a much lower on the risk list. They were down to position 65, and the way that was achieved was by executive engagement. It was by appropriate workforce gaps being filled. It was by regional and national and local support on top of the very basic management of the PTL processes within the organisation. Next slide, please. So what about the transformation that we've begun, or has been begun? It is being done by many, many people around the country. One of them is the separation of urgent care from elective care, the creation of surgical hubs that facilitate high volume, low complexity surgery. The ambition is that these hubs will deliver surgery 2.5 sessions per day, 6 days a week. Because of workforce constraints, that's not possible in many places at the moment, but that's the ambition and that's the direction of travel. And if we do that on cold elective sites, then we can increase the number of patients that get to theatre first on the list. We can reduce the number of gaps between theatres. We can enhance discharge rates and day case rates and improve our productivity. We can also look at digital help. Digital will help. It won't solve everything, but it's beginning to make its presence felt. A large part of the investment in the NHS that was provided for us has gone into digital solutions, which to date are using robotic processes to automate many of the backroom tasks of waiting list validation. But coming just around the corner, we're beginning to see the use of digital pathways to support a number of specialties, most notably at the moment dermatology, and the enticing possibility that at some stage in the next year or two, we may be able to use artificial intelligence to enhance some of these processes even further. Next slide, please. Within the outpatient service, I think I said earlier that 2/3 of the waiting list, 80% of it is in the outpatient service. So we do need to do things differently. And a number of initiatives are gaining ground. For instance, specialist advice and guidance was beginning to happen before the pandemic, but has grown considerably. And this is a way whereby GPs can direct questions, queries to hospital consultants, specialists, for advice, which hopefully will allow the patient to be investigated and treated closer to home in a more timely fashion. It has taken legs, it's grown, it's growing, and it's providing a significant pathway for many patients now. At the back of the pathway, there's this thing called patient-initiated follow-up. And it's one of those things that perhaps we all take for granted. But when I get ill, I just phone up and make an appointment with my GP. I can't do that with a consultant. But if I had a long-term condition, what would it be if I had arthritis and if I had an arthritic problem, if I was able to phone up and get an appointment with my rheumatologist within the next few weeks? And this is called PIFU, whereby patients with long-term chronic problems don't get routine appointments every 6 or 12 months, which is the historical way of doing it, but get those appointments when they need it, which often isn't as frequent as we're originally booking into the system. That's called PIFU, and it's growing, it's gaining legs in lots of pathways and in lots of specialties. And I think will take some pressure off the outpatient services even more as time goes by. Next slide, please. Looking forward, we really do need to do more about outpatients, and the numbers involved in the outpatient service are mouth-watering. 40 million follow-up appointments a year, many of which, and I speak as a clinician, have no clinical value. And you think to yourself when you've seen the patient, oh, they really didn't need to come to see me today. Well, we do need to do something about that and ensure that patients who come back to a clinic need to come back to a clinic. We've seen a very rapid increase in virtual consultations, and that needs to increase where appropriate so that patients can get their advice closer to home. We have 10 million patients who don't attend, clearly a wasted resource, but we're beginning to understand that this relates significantly to health inequalities, and we could do a lot more to reduce those number of failed attendances, and hopefully that will also be associated with an improved resolution of dealing with the health inequalities that do drive a lot of patient behavior, both in outpatients and in the wider healthcare service. And then 9 million cancelled appointments each year. All of that describes wasted capacity. In reality, that wasted capacity could be put to better use, and we need to work out ways of doing that. Surgical transformation has been based primarily around separation of elective and urgent care with the creation of the surgical hubs, many of which will be doing more and more day case surgery. In my own specialty, for instance, the day case rate for urology is about 75%, but we need to push it up to 85% to get more patients in and out of hospital faster and get their treatment faster. And with the hubs and with the dedicated facilities, we should be able to improve the productivity within those hubs. The targeted investment fund has given us an opportunity over the next 2 or 3 years of really building a much bigger elective capacity. And the numbers on the slide show that over 1,000 extra elective beds, over 100 extra critical care beds by March 25, and in 50 new surgical hubs, which will help to separate elective and emergency care going forward and improve the resilience during those winter pressures with which many people will be familiar. Next slide, please. You can't make a diagnosis without diagnostics, and the creation of the community diagnostic centres began 2 or 3 years ago and continues to grow in strength. The ability to offer far more tests, whether it's cross-sectional imaging or whether it's endoscopy, and that capacity for more tests, more scans, will only increase over the next few years. We're exploring collaboration with the independent sector to also enhance this with extra independent sector provided CDCs. And what we need to do is link up a little bit better with cancer services and with the hubs to ensure that diagnostic tests and perioperative tests can all be done within the hubs. In my own specialty, we're beginning to look at delivering outpatient services within the hubs where you've got the tests on site and you can look at the one-stop visit for the patient in the hope of getting their diagnosis and hopefully their treatment all done within a single visit. We're looking at ways of making our cancer pathways better. I've always been impressed as a urologist with the work done by the prostate cancer doctors who've really streamlined a burgeoning service because of the use of PSA. There's lots more men being referred in with possible prostate cancer, and given the demands on that pathway, the need to deliver rapid testing, rapid diagnosis and treatment where appropriate has become ever increasing a challenge, and that pathway has become really slick in many places. But there are other pathways. I was on a call this morning whereby teledermatology, whereby a GP takes a photograph of a lesion, it's emailed into the trust and a decision is made on the appropriate pathway for that patient on the basis of a photograph taken in a GP's practice. And there are similar enhancements in many of those cancer pathways. As I suggested earlier, we need to make sure that the CDC expansion supports rapid cancer diagnosis, and that is happening. Next slide, please. One of the challenges is that our problems and our wait times or waiting lists are not spread evenly geographically. This is a graph which shows with the big dark bars the numbers of patients currently waiting for 78 weeks at the end of November. And you can see that the Midlands and the Northwest and to some extent the Southwest are under greater pressure than other parts of the country. And there are inherent reasons for that, whether it relates to social deprivation or simply to geographical issues. That means that we do need to provide individualized support and challenge both for regions and for ICBs and for individual organizations. Next slide, please. So there's been the creation of a regular tiering support for organizations that are having particular difficulty in delivering both elective and or cancer care with regular management support and challenge from NHS England and from regions being developed over the past 12 months or so. In the past 2 months, we've developed a series of clinical support systems for the most challenged specialties and the most challenged organizations. And this is just one of the slides that we would talk about in terms of our input into those organizations. This one's particularly about surgical patients. Has the waiting list been validated? Has the patient been asked whether they still want their operation? Has appropriate pre-assessment been sorted? And then is there theatre working as efficiently as it could be? Is the day case rate appropriate? Are patients being sent to hubs when it's appropriate for their care? And is a same-day ambulatory care system in place for the urgent care to take a little bit of pressure off that elective service? So this is the sort of thing that we're doing to help different organizations do better. And on all the calls I've been involved with and all the visits I've been made, I remain tremendously impressed by the hard work and diligence of the people in these specialties, even when they appear to be under enormous pressure. Their willingness to take on new practices, to change the way they do for the benefit of patients is considerable. Next slide, please. Looking forward, what do we need to do? Well, I think we can never have too much input from our patients, whether it's from the patient representation groups or individual patients. This is a service for patients. It's not a service for the staff. I think there's a recognition that greater clinician input can help with the delivery of elective care in a timely fashion, so that we reduce variation and we enhance the service for patients. But we do need to get those basics right, to understand what the list is, to ensure that it is valid, it is prioritized appropriately, and that patients on there do need and want that treatment. Technology will help, and I think will offer lots of opportunities in the coming years, but it's not the solution on its own. We do have to get those basics right, and we're working to try and deliver that and enhance technology and digital solutions where it's proven to be effective and safe. The change in the NHS structures, I think, are just bedding in, and so we need to learn how the ICBs can support the delivery of elective care within provider organisations, and those systems are developed to varying extents around the country, but are increasing. And I think at the bottom line, everybody on the call will be proud of the National Health Service. It's one of our national institutions, and having worked in NHS England for 18 months or so, I can assure you that the NHS continues to strive above and beyond, really, not only in times of crisis, as during the pandemic, but in also dealing with the after effects and dealing with the elective backlog. Thank you very much.
Fascinating to hear what transformations are going on at Leeds Teaching Hospital, and also really nice to hear you say that the NHS is doing a good job. It's very easy to be distracted by negative headlines, but certainly at these panel discussions and these events, listening to all the fantastic brains that are putting a lot of thought into how to solve the challenges is always really heartwarming for me. I am looking forward to this panel, as yet again we have two this time fantastic speakers. We'll be discussing the present and future of patient flow, along with our event partner Accurex, and the benefits good flow has in working towards reducing the NHS backlog. With waiting times increasing in the backlog, the number of patients medically fit for discharge were released from hospital at a rate of 39.9% a day. That's according to the NHS Confederation. This figure has an impact on the ability to bring vulnerable and sick patients through the healthcare system, as beds are being taken up by 13,000 people a day on average who don't need to be in hospital. This is made worse as the footfall in A&E departments continues to rise, whilst capacity to release patients for care at home using virtual wards and remote care networks falls. In October last year, 43,792 patients were recorded as being held in waiting rooms in A&E for more than 12 hours for admission, a record high for the NHS. However, it's encouraging to see that the number of patients at major A&Es was at a record low in the same month, with 54.8% of patients waiting less than 4 hours to be seen. So in this discussion, we'll focus on the impact new technologies can have on patient flow, ultimately, hopefully helping to reduce the backlog. So don't forget to put your questions on the right-hand side of your screen if you'd like to join the conversation. I really hope you do join the conversation. And I'd like to introduce you to Dr. Satya Raghuvanshi, Head of Clinical at Accurex, and Rob Salter, Innovation Scientist for Cwmtaf Morgannwg University Health Board. I'm not sure how that Welsh went, but Rob, do you want to correct me there?
Morgannwg, very close.
Go on, try it. So let me know what it should be.
Cwmtaf Morgannwg.
Oh, not too bad. That wasn't too bad.
Very close. Yeah, very close.
As you know, we've had one guest drop out through sickness, so we have a little bit more time to breathe on the panel than normal. So I thought I'd start, Satya, by just asking you just to tell us a bit about your role as head of clinical at Accurex and what that actually involves.
Yeah, absolutely. Very happy to. And thanks very much for having us on the panel today. So Accurex, I think for those of you who may be unfamiliar with us, we're a software company that's used to connect staff and their patients across every care setting in the NHS, so from GPs to acute community, mental health and ambulance trusts. And our vision, very uncontroversially, I never have much challenge around this, is really to make sure that we're supporting a health system where everybody who's involved in a patient's care can communicate with each other. And that's really in order to deliver better care. And we know when that works well, that's fantastic and really helps to improve patient flow. But when it doesn't work as well, and when the system is fragmented as it is, that can really impact the ability of healthcare professionals to deliver effective patient care, but also the experience and trust that patients have in the NHS. So our kind of mission and overall goal really is just to make that much easier for everybody involved.
And we'll find out during this panel how you're actually doing that. Rob, as we do have the luxury of a little bit more time, just tell us a bit about your role at the University Health Board and as an innovation scientist.
Yes, so it's a new role as an innovation scientist. So it's supporting a new department called ICTM, Innovation and Improvement. And my background in the health, I actually wrote the software for our patient flow, and I've also designed software for our care package planning. And my role is I'm a consultant innovation scientist, so I work for many organisations. And one of the other roles, organisations I work with, we've done a mobile diagnostics unit to bring outpatients out into the community. So as a scientist, my role is tackling the technical issues to support the clinicians.
Ah, it's fantastic. Gosh, and you wrote the software for patient flow. That's going to be certainly added to my list of things I'd like to ask you both. Satya, just let's come back to you. Talk us through some of the biggest challenges of moving patients through the system.
I think, as Ian's kind of already spoken about, it's no secret that the NHS is under severe pressure. We hear daily about blocked beds, delayed discharges, long waiting times for elective care or access to GP appointments. I think fundamental to this is at the centre of all this are the people. So that includes healthcare professionals, the workforce and patients, but also the systems in use. And I'm not going to pretend to be an expert on the workforce challenges, but I think I can speak more confidently about the systems. I think the scale by which patients have to move through the system makes it feel like a very daunting task, especially in terms of ensuring consistency and really then that having a knock-on effect on improving waiting times. I think fundamentally good patient flow relies on easy collaboration and information sharing between lots of different care settings. And if we take just a very, very small example of that patient flow, so for example, when you're discharging a patient, my background is paediatrics, so I know the challenge of this specifically around children, but there's lots of different steps and activities involved. That includes communication to the patient or their family members, completion and sharing of discharge summaries to the GP practice, medicine reconciliation and referrals to community or social care, etc., and lots of coordination that's happening. And so when the system is under so much pressure and the technology that should be enabling easy collaboration and information sharing isn't in place, it really just does not work as it should or as well as it could. And I think the staff not being able to quickly and easily obtain information, communicate with other healthcare professionals, lead to kind of increased pressure on the system, but also feeling like you're not able to do your job as well as you'd want to do. And, that has a knock-on effect on workforce morale. And I think for patients, ultimately, it leads to reduced patient satisfaction and trust in the healthcare system. So I think that squeeze on kind of moving patients efficiently when you don't have the right resources in place is really adding to this, is one of the biggest challenges in terms of kind of thinking about and impacting elective recovery.
Rob, when you wrote the software for patient flow, what inspired and motivated that? I mean, could you see, as Satya was saying now, the impact of things not flowing properly, the impact that has on healthcare staff and of course patients as well. Was that what drove you to try and put something in place that would make things more efficient?
Yeah, and it was also the use of digital, the methodology that these things. We were still reliant on emails and Word documents, managing patients in spreadsheets, and it, from a digital point of view, it just it's straight away said this isn't an efficient way of managing patients. The replication, most of our listeners would have gone through some sort of digital process where we've taken forms and put them into digital forms, and we've given up. But it's a lot more than that. When we looked at how patient flow worked, it's exactly what Sajid just said. It's about the communication. It's about understanding people's roles, people's pain points, why the barriers for things. And on a form, you can't understand why a barrier was being created. You need dialogue. So when we looked at the patient flow system, and we were experiencing typically 30 days to transfer a patient from a primary hospital, from their acute care to the localities hospitals where they can recover. Instantly, we got that time down to about 3 days, because we tackled it from the point of view of how do people want to communicate. We made sure the platforms were what they're familiar with, and allowed the conversation to be about how they do their job and what they need to get there, and not make the focus about, well, how many days has this patient been sat in the bed? How many days has this happened? With that, we introduced RFID technology in hospital, patient wristbands as a trial to look at patient flow in some non-scheduled care, and those sort of things can be automated. They don't need to be clinician time. Letting the clinician focus on what the problem is, on the actual patient, the person-centric reason why that patient is not moving down the chain, and letting that be a dialogue. And we saw that the flow was much, much better and very dramatically different.
Oh, I can imagine. And Sachi, technology which opens digital channels of communication between patients and their healthcare teams, I would imagine can really help address the situation. I mean, communication and the right communication is really key here, isn't it?
Yeah, I definitely agree. I definitely echo what Rob said there about kind of really understanding the pain points and actually what are the motivations of each person who's involved in that process. I think one of the things that we spend a lot of time doing is observing and shadowing healthcare staff and their patients, and we the whole company, that's kind of regardless of what your role is, you have to go and spend some time with people who are navigating these systems, and I think the role of digital channels of communication, but there's obviously kind of lots and lots of benefits, but the thing that we hear kind of firsthand from some of that observing and shadowing is that without the right tools in place, because you're often navigating multiple systems, multiple channels, it's really hard to make an indent on improving that experience for both healthcare staff and patients. And so what that means is that each stage, the chance of delay increases, and the kind of wait time for responses or requests for additional information to move the patient forward in the next step also increases. What also happens is the patient has no visibility of that. So they feel very out of the loop about what's happening for their care. And so I think we've seen very simple technology like SMS to message patients and let them know your referral's been made or your outpatient appointment's going to be on this day, as well as making it very, very simple for healthcare professionals to communicate with each other across the system. And some of the uptake we've seen now with things with like the NHS app and moving notifications and informing patients through the NHS app, which they're also interacting with, can actually be easy to implement than I think first imagined. They're certainly really scalable across the system, but they do have to be incredibly simple for patients and healthcare staff to use. It shouldn't be another system on top of the multiple systems that you're using. It should feel very integrated to your workflow.
And is there a backup, Sacha? I'm just wondering, I mean, you know, massive advocate myself for digital and the transformation that it can bring. But as David's just put on our chat, David says, ironically, I'm doing a surgery this afternoon and the digital tools aren't working, exclamation mark. So are there things in place, you know, for digital doesn't, you know, can sometimes let us down, can't it? Is there a backup for things like David's situation right now?
Yeah, absolutely. I mean, sadly, some of it is just defaulting to pre-digital tools and solutions and whatever you've got in the moment. NHS staff are incredibly resilient with incredibly limited resources and will make the best of the situation that they have. It doesn't fundamentally, digital tools will be appropriate for lots of care, but they won't be appropriate for some patients. And so you do need to have backup ways to continue to support that care, and that might be still a patient phoning in, for example, for a practice, but somebody making the second part of that process easier. So a proxy can submit information on behalf of the patient, or actually the GP practice can interact with the more patient-facing tool. There are solutions. I think the challenge is when there's downtime, it's making sure that as a supplier, certainly from our perspective, you can get things back up and running very quickly. But yeah, I think we've always got to be mindful of that digital tools won't necessarily reach everybody in the way that we would want.
And Rob, Nigel puts on the Q&A section, I've read there are 50 forms to be completed for someone in an acute bed before discharge. Is that correct? Surely it can be simplified. I don't know, that's something you've knowledge of there.
Yes, there's a lot of photographs going around on social media of doctors lying on the floor with all the paperwork next to them to show them that there's the vast response to it. And and we are tackling the e-forms, to try and reduce it down and to remove the fact. We can easily say the top third of every form is probably duplication, because without the top third, you wouldn't know who the form. So there's obvious duplications here in why we're filling the forms in. But going back to Sarah's point earlier about the backup and the fallback, one of the observations we noticed was we produce reports every day of your list of all the patients in beds that need to be your working list for the day, and without thinking, we just created it as a simple sort of spreadsheet style form. And when we actually watched the discharge liaison teams, they needed a notebook. They didn't want to carry iPads around with them because everything's got to go in a little pocket on their uniform. But by being able to change the way we print the forms out every day, so they had plenty of space to write notes down, plenty of space for bits of information they knew they were going to pick up throughout the day. It made their fallback to paper more efficient. So where we assumed it would be a paperless solution, the actual efficiency was in a hybrid solution where the paper was valuable to them, and that sped up the data entry points then, so that they had all the information on the form. So when they finally sat down at their desk, that's when they have their cup of coffee and they can start getting the system updated again with the information, which they didn't feel would be efficient if they had to walk around with iPads, and it was constantly that just filling in forms, electronic forms all the time. So it did show that the electronic forms approach might not be the perfect solution, and it's got to be some form of hybrid.
It's never going to be a one size fits all, I don't think, is it? And that is a good example of hybrid. Sachi, do you have some examples or a really good example perhaps of how your software really is helping with patient flow? If you had to pick one thing that really brings it home for our audience, what would you say that would be?
I think I'd probably pick one where we're doing it quite well across primary and secondary care, so it's not siloed within one kind of area. So actually very similar to the example that Ian mentioned around dermatology pathway and digital pathways for dermatology. So we have a very simple tool by which a patient can get in contact with a GP practice using an online form. And within that, they can also submit an image when they submit that form. So for a patient with a skin lesion or a funny rash that may not need emergency care, they can certainly go through that kind of digital pathway. And like a proxy, somebody who's kind of acting on behalf of the patient or a parent acting on behalf of a child can also use that. And then we do some verification against both the GP record and the national spine. Once they actually submit that form, there are simple questions about their symptoms, and it either goes into an admin flow or a clinical flow for the GP practice. And in this case, something like a skin lesion would be clinical. So the GP can review that information, collect additional information if they want, via structured data capture or questionnaire. And then at that point, they may want to bring in the patient face-to-face, so they can send the patient a self-book link, or seek some simple advice and guidance from a dermatologist. Without having to navigate away from their system or the patient record, they can send off that request to dermatology at their local trust through kind of a very curated directory of services. And what we've seen is when that goes across, GP practices typically see 98% of messages being responded to within 48 hours, which is phenomenal. And when they receive a message from a secondary care clinician, so when the dermatologist replies, for example, typically practices have acknowledged that message in about 9.5 minutes. So that is just really simply improving that experience. Once that patient if that patient needs to be referred to secondary care, then the same kind of use of services to keep the patient informed, patient-initiated follow-up, all of those pathways are also in place. So actually throughout, there's a couple of things happening, but the main one is healthcare professionals are interacting with one system, and patients are also only interacting with one system, but they're also getting that information back to them to know where their referral is, what's happening with their care, and so they can be fully informed and do things like booking with a self-book link, for example.
That's a really good example. Rob, just your thoughts on mixing secondary and primary care diagnostics and the impact that has on patient flow.
Yeah, it's something that I'm noticing. When we looked at now through decentralized care, if you look at the rationale for the way patients come in secondary for their diagnostics, and we had it in with Dr. Eardley in the previous conversation about the perioperative and post-diagnostics, and then sort of the diagnostic testing. They're different types of tests, and I don't think we get efficiency by mixing the two systems, because you're mixing two different mindsets. As an example, as a basic use of healthcare, your GP sends you in for to rule out things, and again, that was alluded to earlier about why are we seeing these patients? They didn't need to come for this test. Well, the GP needed to rule them out. So we're getting patients coming in for ruling out, whereas the patients in A&E is going in for confirming. So, and you would ask, well, isn't that the same test? But it's not. Ruling something out and saying it is something are two different things. And in terms of the flow, it has a massive impact, I think, because if you suddenly have an 8 to 10 week wait heart scan just to have your heart scan ruled out. Okay, now we're going to go for a chest X-ray, another 6 week wait. Well, it's not that. Okay, so we're going to try you with this medication for a month, see if it's that. We've given a patient journey of about a year, and we still haven't got to that diagnostic, which is what they were expecting when they first went to the GP. And it's, do we need to think about our primary care GP-led diagnostic tools being about getting to the problem quicker, and then leaving the secondary care diagnostics about, is the patient now getting better, and can we get them home quicker? And so I think, and I think the solution there would be decentralized diagnostic centers or diagnostic hubs, and bringing diagnostics closer to the communities.
Yes, exactly. I'm just wondering whether, Rob, we've kind of inadvertently removed the patient journey from systems and process thinking, and how can we reduce the backlog and improve waiting times and still try and keep that patient journey intact? That's quite a difficult one to solve, I would have thought.
Yeah, and that's why I'm sitting here in a conference in South Wales, and we're all talking about system thinking and processing. And I spent all morning looking at maps on PowerPoint presentations about how patients have been flowing through systems and how we move from here and here. And it's always linear. It's always a straight line, even though it curves all around the page. It's still a straight line. But and what we saw when we did RFID modeling of patients, they don't go in straight lines. They quite often go round and round in circles. and you sent back, and quite often when you get a confirmation that it's not something, the whole process is looped around again. What we're seeing is that the patient journey seems to be very circular and looping back on itself, very repetitive in terms of how they go through the processes. But we map them as these very linear, straight line processes, and so we're not actually looking at what's happening to the patient. We're looking at it from referral to confirmation of diagnostics. Well, that's not the patient journey. The patient's journey started waking up in the morning with chest pain.
Yeah,
and
it's so difficult, isn't it?
It ends up going home to their family safe and well.
It's so difficult when you realise the numbers involved. I mean, when Ian was speaking a minute ago, Satya, I think he mentioned that there's 9 million cancelled appointments. Well, it's then when you think that, when there's something wrong with you, you're very much aware of your patient journey. But I don't envy you trying to solve these solutions, because you're dealing with so many different aspects to try and make it a smooth journey. And I'm just thinking of unnecessary appointments, Satya, and the role that maybe tech can play in reducing those, to free those up for patients who do actually need the care.
I think there's probably a couple of roles that tech can play. I mean, if we start from, talking about the elective recovery challenge, which is patients are being referred, they've still that referral times treatment pathway. What we tend to see is kind of at different stages of that, currently trusts are relying on quite antiquated methods, which is using tech that doesn't work, but also defaulting to everything needs to be a face-to-face appointment, which is a little bit to what Ian spoke about earlier in terms of the patient-initiated follow-up pathways. Now, those are patient-initiated to the point a clinician still needs to validate whether a patient needs to be seen or should be seen, and whether it's appropriate for them to go on a pathway where they initiate that care, or whether actually, they do need a routine appointment to kind of see how they're getting on, because there might be a number of reasons. They might be on an immunosuppressant that needs more intense monitoring, etc. So I think there are, when we're talking about unnecessary appointments and freeing up unnecessary appointments in the system, the first thing is to making sure that patients can move through, once they are, certainly from a secondary care perspective, once they're referred into that service, and then beyond that, giving them opportunities to lead on their own care. So a real life example of this is we're working with University Hospitals of Leicester to do just that. So in the last, I think, 6 weeks, we removed about 14,000 patients from their RTT pathways and overdue follow-up list, because those patients have told us they either no longer require care because they've had treatment elsewhere, or their symptoms have resolved. And so for some of those patients, it's then appropriate, if their symptoms have been resolved, but actually from a clinical perspective, you still want them to be able to contact the service or have access to care. That doesn't need to have an appointment in the future, booked in for 9 to 12 months routinely, where it may be of less value. And so moving some of those patients onto patient-initiated follow-up pathways helps to manage that kind of burden and reduce the volume of unnecessary appointments that we're creating in the system. Now, it's all supply and demand, so you've also got to make sure that your referrals coming into the system, it's not a leaking bucket in that sense, that you're removing patients, you're moving on to patient-initiated follow-up pathways, but you haven't really looked at your referral process. So this is some of the work that we're doing around with University Hospital Leicester, and what we've seen is doing that validation piece of whether patients need to be seen, offering alternatives to care where it's appropriate, actually removes, for them, they remove more patients than are being referred, which is actually a really interesting change. And so now we're going to start looking at some of the referral process, see how we can improve it and streamline that. And all of that should try and mitigate in different ways the need for unnecessary appointments.
A lovely answer there. Rob, how big a contribution does community care and social needs make to support that better, smoother patient flow, do you think? I was interested as well when you talked about your mobile diagnostics unit.
Yes, and what we saw with the mobile diagnostics is getting it's literally outpatient department on the back of several lorries that we take out to the community. And that had immediately massively reduced DNA rates, because we were where people want to be. It was more convenient, and we saw crazy sort of behaviours. On our hottest days in the summer, people would rather have an ice cream than a diagnostics test. And we were banging our heads against the wall. We got a very expensive empty unit, and the patients weren't turning up, and it was because it was also so realised then that this is all about patient motivation, patient behaviour, and if we don't factor that in and use that, we'll never get to these numbers under control because we're not understanding what's creating the numbers. Cwmtaf Morgana with the Mobile Research Unit, they managed to clear their respiratory backlog.
Wow.
But in the last month or so, we suddenly saw a huge spike in the DNAs. And we're like, well, it's heartbreaking when you had such a successful thing. You thought you were going to hit the finish line with a zero backlog, and all of a sudden it spikes up and nobody's turning up. We stepped back and realised, well, actually, we've got to the bottom of the bucket.
Wow.
These patients never wanted to turn up for these diagnostics. These are never be on RTT lists, but what we had to do was change tact. We had to change the conversation we had with the patients. We learned some behaviours were going on. Patients were scared that they'd lose benefits if they had the diagnostic test. So that's the reason why they kept missing the tests. So we need to find out how we filter that out, because we're panicking about large numbers of patients needing testing and needing to go through the system. But actually, that they don't. The numbers are not correct. And if we look at those patients that got behaviours, which mean we're never going to see them turning up to outpatients appointments, they need a different type of care and a different type of approach in social care to fix the problem. And it's not healthcare fixing their problem.
Were you satisfied, Rob, just thinking of a conversation we had earlier, and I can't remember now which guest said it. Were you satisfied with the quality of the testing? That was something that was questioned earlier on in the conference, as well as making sure those diagnostic units are properly in the community, because we heard from one guest that their unit was actually in the hospital car park, which of course then still gave other problems because it wasn't in the community. Therefore, parking was still an issue and it was clogging up the whole system.
Yeah, we predominantly used supermarkets, rugby clubs, we even used an airfield, but they were all places. We made sure there's loads of parking there. We made sure there's free parking, and ironically, when we did some testing of the unit and commissioning, the worst places that we found to park the unit and to work on was the hospital sites where we had to do commissioning. It was so much easier to go and do it at supermarkets and sports grounds and stuff like that. So getting it out into the community is far better. We didn't want these patients anywhere near the hospitals, and this was just coming out of COVID. The patients didn't want to be anywhere near the hospitals. They were COVID and still stayed about coming onto site. And
the quality of the testing you were satisfied with as well?
Oh yes, we went to lengths. We could quite happily say that the mobile research unit we built was a higher standard than the actual hospitals the patients would have gone to for their tests. It is achievable.
That's really, really impressive work. Satya, I just want to end by talking to you about the fact that, you're a digital supplier. What do you need to see from the NHS Trust leaders to be able to roll out the solutions that you provide successfully? Because I would imagine with the people you work with, it has to be very much a two-way street to work properly and well.
Yeah, I think it echoes very much what Rob's kind of said around really understanding what are the challenges in delivering care and understanding that from a patient perspective and the people interacting directly with the system. Because I think if you're sitting in a room looking at your patient pathway and like Rob's talked about, it looks very linear and you find out the patient's going around in circles, you need to redesign that pathway to reflect that. I think especially given, over the last couple of weeks, we've seen NHS tech funding being cut by more than half, changes in operational guidance and the financial incentives that trusts have to tackle some of these larger problems. I do think in terms of what we need from trusts and suppliers, we're going to have to get more creative in the partners that they choose and how they work with them. And that might mean a move away from traditional kind of procurement pathways or solutions that aren't focused on values and value-based assessments. So that really is a question of, are you working with digital suppliers that are not motivated by selling, but are motivated by the value that comes out of working together, the patient experience, and actually the number of staff who are able to use those solutions? So I think there's a lot of shared responsibility there, in terms of kind of getting solutions rolled out that actually meet some of the challenges that we've talked about today. And then I also think it doesn't end at that point that you kind of made that collaboration. You've got to be on the ground, making sure it works, making sure that there'll always be outliers and edge cases that you haven't thought about that maybe you could factor in actually to how you're delivering that care. And are you doing the best by the people that you are working with? And I think it fundamentally comes down to some of that, but moving away from these very traditional kind of pathways of choosing suppliers and procurement, and focusing far more on value-based assessments.
Well, thank you so much. I think that both of you, what shone through from both of your answers today is the passion, and that it's not just work and it's not just a job, that you really do care for the patients, have the patients at the heart of all this. And it's been putting questions on my Q&A. My screen actually froze on the Q&A, so the trials and tribulations of doing a virtual event. So if you did put a question in and I didn't ask it, it's because my screen froze. But Satya, Rob, thank you so much. It was really nice that you joined us on this panel, and really enjoyed the content. And a massive thank you to everyone indeed who's joined us for the whole conference today. I'd also like to thank our partners, as of course we couldn't go forward with these events without your input and industry knowledge. And I look forward to seeing as many of you as possible at our next event on NHS Net Zero, which is taking place on the 5th of April. Please do share the word with your colleagues. They, of course, would be very welcome too. And just a quick reminder, as you know, today's event was CPD certified, with 1 CPD point earned for every hour of live content watched. So if you'd like your certificate, then please email marketing@cognitivepublishing.com and they'll send that out to you. So from me and everyone at NHE 365, thank you for attending this online conference today and giving us your time and attention. Have a great rest of the day. I'll see you soon.